And we have one of the most eminent faculty, Dr. Rajani Surendar Bhat. Warm welcome to you, madam. And she has completed residency in internal medicine and fellowship in pulmonary diseases and critical care medicine at the Albert Einstein College of Medicine, New York. And currently, she is an elected member in Governing Council, Indian Association of Bronchology. She's also a part as a mentor on Death Over Dinner India. And areas of interest are interventional pulmonology, ILD, medical humanities, palliative and end-of-life care, burnout prevention, death literacy, communication sciences, healthcare activism, medical law, and ethics. She is also active in the fields of education, research, implementation of best practices in palliative pulmonology in India. She is one of the most eminent faculty who can lead us and guide us in this respiratory about palliative medicine in respiratory system. And we are so grateful to have you here, madam, for taking us this session. Thank you, madam, and over to you.
Thank you so much for that warm welcome. It's always a pleasure to come back to interact with people, with the growing tribe of doctors and nurses and healthcare professionals across India who are engaging in the field of palliative medicine through the ongoing efforts of Pallium India and the Project ECHO. It's been a long and very fulfilling and fruitful association for us that I hope will continue. And I hope all the participants today find it useful as well. So without much delay, I am going to start my screen share. Just a moment. Is my screen visible to everyone?
Yes, ma'am.
Thank you. Thank you. So what we'll try and do is cover just an idea of what is the current situation of chronic respiratory disease or the burden of respiratory disease in India. What is the situation of palliative care for respiratory disease? What are the issues that the patients face? And what are the ways in which we can help our patients? And we'll try and cover that in the next hour. I know that we have a case to discuss as well. So let me try and cover as much material as I can and then try and get to the discussion of the case, which I think will offer far more practical insights. So we'll try, as I said, to discuss the scope of palliative care and respiratory disorders, the burden of breathlessness. And also let's see what happens with, is there an issue that we face amongst doctors and healthcare, the caregivers as well? Is there a resistance to palliative care for people with respiratory issues? So if we look at the current burden of respiratory disease in India, this is based on a very large study, which was a longitudinal study across 25 plus years. As you can see, Dr. Sandeep Salvi and many other senior pulmonologists from across the country contributed to this study. And it's a large population that is studied, and what it showed us, this is the absolute broad outline. It's a very in-depth study looking at every aspect, different types of respiratory diseases. But the big picture is that we are home to 1/6 of the world's population, but we are also home to 1/3 of the world's population that suffers from chronic respiratory disease, which causes some degree of disability in people's lives. So that's, we're carrying double the world's burden. Any other country, if we look at it, how many people with chronic respiratory disease you would expect to see? India has double the number of patients. So respiratory, chronic and advanced respiratory diseases come with a large symptom burden for a long period of time. So clearly this is an unaddressed issue across the world, but most particularly in India. When we look at what kind of palliative care is available for patients with respiratory disease. Now, this is actually a study that's based out of Sweden, which has, government-funded healthcare and access to palliative medicine for patients who have life-limiting conditions. And this was a study which looked at patients who need oxygen. So they had a combination of patients who have COPD and patients who had cancer and other conditions requiring the use of oxygen. And what they realized was that, these are advanced diseases and death was expected in COPD patients as well as cancer patients. But the COPD patients were not referred as often to palliative care or given extra attention to their symptoms of pain, anxiety, depression. They were not offered home care palliative services, fewer end of life discussions, more likely to die in hospital, more likely to die in ICU and on ventilators. And similar situation if you look at interstitial lung disease, pulmonary hypertension. So what ends up happening is here we know that there are patients who have a chronic life limiting condition, which is getting worse and worse and worse. Their symptom burden is rising. And if you had a label of cancer, you were more likely to be referred to palliative care. And somebody would be trying to make sure that your pain, your depression, your breathlessness, your preferred place of death when the time comes, all of these would be addressed and patients and families would be counseled. But this was not given for patients with chronic lung disease. So if that is the situation in countries which have awareness of palliative care and government funded healthcare, we clearly have our work cut out for us. And it's just something we need to sensitize ourselves to remember that we should offer this to patients with chronic respiratory disease as well. We can come across respiratory issues in palliative care in a number of patients. So you have patients who have primarily respiratory disease. If you have respiratory symptoms, which is breathlessness, which is cough, chest pain, heavy secretions, hemoptysis, this could happen in patients who have respiratory diseases like COPD, like lung cancer, like pulmonary hypertension. And that also it could be cancer or non-cancer respiratory diseases, right? And you would also have non-respiratory symptoms in advanced respiratory disease. So my patient with COPD, cor pulmonale, for pulmonary hypertension, for lung cancer, could also have severe pain, could also have anxiety, could also have depression, could have sleep disturbance, could have nausea, could have constipation. So there are non-respiratory symptoms as well in advanced respiratory disease. And if you look at any end organ failure, you look at end-stage heart failure, you look at end-stage liver failure, you look at end-stage renal failure, you look at neuromuscular diseases, all these patients will have respiratory symptoms as their primary disease progresses. They will have either breathlessness, or they may also have hemoptysis, or they may also have chest pains. And they may have cough, difficulty in clearing secretions, aspiration, pneumonia. So respiratory symptoms are going to be faced in the majority of patients as their disease progresses towards the end of their life. And as we know, in the end of life, one of the modes by which the life ends is either going to be cardiac death or respiratory death. And therefore, all end of life discussions do involve how do we address respiratory symptoms. Keeping this in mind, it's important that we familiarize ourselves with what is the respiratory symptom complex. So there is breathlessness, hypoxia, cough, secretions, hemoptysis. All of these, whatever be the underlying conditions, will lead to a worsening situation of respiratory failure. Some patients may have mechanical issues that need to be addressed, which could either be pleural effusions, which could be airway obstruction due to tumor, due to mucus plugging, whatever be the situation. So there's a large complex of symptoms, and we need to address all the symptoms that the patient is experiencing. I'm sorry, my slides are, yeah. So the associated symptoms, as I mentioned, pain, nausea, constipation, loss of appetite, muscle wasting, cachexia, sleep disturbance, dry mouth, anxiety, depression. What this tends to do as the patient gets more and more breathless or may require oxygen and is dependent on oxygen is that the patient ends up becoming isolated. They start moving out of the house less. From moving less outside the house, it starts becoming moving less outside their room. They want to be close to a bathroom. They will stay in their room. They'll stop their activities. If they have, for example, sometimes you have patients with COPD or a lung cancer, and there would have been a history of being a tobacco user in the past. And the patient is sometimes racked with guilt that, oh, I brought this on myself. And we as medical professionals sometimes don't help, with the labels that we use: smoker, former smoker, reformed smoker, whatever you call it. You've given a label to the patient, and somewhere that patient starts feeling that they are to blame for their own troubles and the troubles they've brought on their family. So language is important, and the manner in which we take that history or repeat it ever in front of them is important, that we're doing it in a non-punitive, not blaming anybody kind of a manner. One of the problems that patients face is that, as I said, these symptoms go on for a very long period of time with our patients. So every time the patient comes, they will tell you they are breathless. They will tell you they're coughing. And we look at their peak flow, or we look at their PFT, or we look at their CT, or we look at their saturation. And then we say, yeah, but these numbers are improving, or these numbers are stable. But maybe the patient is not feeling quite okay, and they end up feeling like their symptoms are being dismissed, right? So we're listening to their lungs, but are we listening to what their experience of life with a chronic respiratory disease is? And that's where I think, the reason why I included this cartoon is that patient taking the stethoscope piece from the chest and putting it in front of their mouth and saying, like, listen to me, I need to tell you something, right? This isn't just about listening to my chest or checking anything else in terms of signs and symptoms and lab results and radiological things, but listen to what is happening to me and see if you can help me with that. That's what we need to work towards as doctors who have a palliative care lens to any problem. It's an approach to any chronic clinical condition, that we approach it with the palliative care lens, where we look at the total suffering of a patient. Breathlessness is one of the most difficult symptoms that people experience in their lives, and most of us have experienced it at some time or the other, but we haven't given much thought. So I actually went to study breathlessness in a more detailed manner to the UK at one point, when I was very troubled by my lack of understanding of how to help patients. And when I went there, I was staying with a family member, a cousin, and then she said, "What have you come here for to train in?" And I said, "I've come here to study breathlessness." And saying, "Is that a really big problem?" Because people have a whole field of study called pain management. There are fields of study about severe symptoms, and specializations within neurology, maybe for headache or something like that. But what is breathlessness as a specialization? And then you start thinking about, think back to what I told you about all the people who will be breathless. I mean, 75% of all of us who are on this call, as we get older, as we experience illness, will experience some degree of breathless. And I hope that the medical profession advances in its understanding of to be able to relieve our breathlessness. So I'm going to very quickly try and lead you through a small breathing exercise. Normally, I prefer to do it with me being on video, but we will try and do it off camera as well. What I'd like you to do is find a comfortable sitting position and stretch your spine out nice and long. Take a long deep breath in through your nose and slowly exhale through your mouth. Inhale again. Long breath in and exhale all the way out. And then now only inhale 1/3 in, not fully. And exhale. Short breath in 1/3 in and out. Exhale fully, completely. Again, only 1/3 in and out again. Again, 1/3 breath in and out fully. Now you can take in a breath as much as you like. Breathe normally. Slow breath in and out as much as you like, as fast as you like. Now take a deep breath all the way in, up to the top of your lungs. Fill your lungs up with air. Don't exhale fully, only exhale 1/3 out. Now breathe all the way in, up to the top. Pull it in, hold it there. Now breathe out only 1/3. Pull it up again. Breathe in, breathe only 1/3 out. Again, breathe in all the way up. Only breathe 1/3 out. Now you can let go, let go, let go, let go. Relax and breathe normally. Would one of you like to unmute your mic and share what that felt like for you?
Madam, when was yoga was introduced in medical field?
I'll come to that question maybe at the end, Dr. Nandini, but let's come back to the exercise and the personal experience that you had of the breathing exercise right now. So I'd like to hear what you experienced when you were breathing right at absolute emptying out your lungs. And what was it like when you were breathing right up at the top, but somebody was not allowing you to breathe all the way in or all the way out? What did that feel like?
Good evening, ma'am.
Yes.
I'm
Good
Dr.
evening.
Priyanka. Actually, when we were able to completely breathe in and exhale out, it was very comfortable,
Mm,
comfortable and relaxing at the same time. However, when we were not allowed to either inhale adequately or exhale adequately, it was very uncomfortable,
correct.
suffocating sensation, sort of
Mm.
like not very good feeling.
Okay, thanks, Dr. Priyanka, for sharing that. Now, think of it, you were at rest, seated, in a position which allows your body to move at its optimal way to breathe, right? I said long spine, seated comfortably. What if the same constraints were applied to you while you had to walk to the bathroom, while you had to climb stairs, while you had to wash your hair, while you had to carry your child, while you had to run to catch a bus, and that was your breathing? That is what our patients with chronic respiratory disease experience every day, every week, every month for years and years. So you've probably already studied about pain as a symptom and how it changes you when you experience chronic pain. Imagine to the same way how dyspnea, how breathlessness will change you as a person, as in your being, because of this inability to do things to the level of control that you would want over your own body. So this is just a little exercise in understanding the patient experience of what breathlessness feels like. Now, dyspnea research lags years behind pain research, but we are starting to understand a lot more of it, mapping out areas of the brain, finding out all the different connects that are there, understanding the emotional aspects of it, the cognitive aspects, what is the pathophysiology, how do what kind of neurotransmitters are involved, what kinds of hormonal influences are there. So just like you have your concept of total pain, breathlessness also is something that you can approach in the same way, looking at the physical aspect of it, looking at the psychological and social aspects of how breathlessness changes you and limits you, and the spiritual dimensions of breathlessness as well, right? So this is the same palliative medicine lens I want you to bring to breathlessness again. This is one of the landmark studies about what happens when you integrate palliative care and respiratory services for patients with advanced disease. This came out of the King's College London Dame Cicely Saunders Institute. And what they did was they assigned people to usual care for whatever respiratory condition they had. And one group of patients received additional support from a breathlessness support service. What they found was that the patients who had the early integrated palliative medicine support from a breathlessness support service actually did much better. Importantly, they had a survival benefit. The patients were matched for the severity of their disease. So you had an equal number of patients who had COPD, cancer, interstitial lung disease, all on oxygen at home. So it wasn't just the survival benefit, though. These patients also had decreased utilization of emergency room services, decreased hospitalization. So look at the benefit that we get with an integrated palliative care service: decreased hospitalization, decreased emergency room visits, and a survival benefit. If this was a medicine, every doctor would be prescribing it. Therefore, anyone who takes care of patients with chronic respiratory disease should consider early integration of a palliative medicine service or approach to their care of patients with chronic respiratory diseases. What does it involve? There's a non-pharmacological aspect of it, which is pulmonary rehabilitation, the use of oxygen or non-invasive ventilation, BiPAP or CPAP as needed if the patient is hypoxic or has high carbon dioxide type 2 respiratory failure, the use of handheld fans, and judicious use of opioids and anxiolytics after optimizing the medical management of the underlying condition. Our golden rule of palliative medicine: treat the treatable, causes has to be first done. Then if the patient has what we call chronic refractory breathlessness, that's when we look at adding on opioids or anxiolytics in small doses for these patients. And of course, here we also include the use of alternative therapies. Now, Dr. Nandini, you asked about the introduction of yoga and breathing. So this comes into alternative therapies, which actually help to manage the anxiety and other aspects of it. There are certain yoga practices which I clearly tell patients not to use, those being anything with forced exhalation. So if a patient should not be doing Bhastrika and Kapalbhati at all if they have any lung problems. If the things that we say is okay for them to do is the slow alternate nostril breathing, so Anulom Vilom or Sitali or Brahmari, these are the kind of practices which act like other alternative practices like mindfulness, meditation, or Tai Chi, chanting. All of these help us with the anxiety part of any chronic respiratory disease which has long-term breathlessness. Therefore, as it reduces the anxiety and improves the overall state of well-being, it is useful for us. It does not help to improve lung function in any way. So that's the part that we need to understand. It is a good add-on as an alternative therapy, but it doesn't either treat the condition or improve lung function in any way. So chronic breathlessness syndrome now has a proper definition, which is breathlessness and disability, which is despite optimally treating the underlying pathology. That's the key over here. We have to optimally treat the underlying pathology. So the patients should have received their optimal doses of bronchodilators or antifibrotics or steroids and immunomodulators, whatever be the underlying condition. So as we understand more and more about the neural pathways and the variability in which diseases respond in different ways to opioids, we are now coming out with better studies to help us determine what's the right optimal regimen of opioids after you have done optimization of treatment of the underlying condition. So when we look at a breathlessness support service, what are we trying to understand? So far our measurement of breathlessness has been somewhat unsatisfactory. So we look at MMRC, modified MRC scales for dyspnea, or we look at New York Heart Association, NYHA grades 1, 2, 3, 4, meaning, patient is has no breathlessness at all, or breathless at unaccustomed activity, or breathless with normal activity, or breathless at rest. But breathlessness at rest is a very broad term. Am I breathless at rest only if I am not moving? Am I breathless even if I have to speak? Am I breathless when I eat? Am I breathless when I move from one position of rest to another position of rest? If I just turn in bed. So as you can see, there are various degrees of limitation even in that breathlessness at rest. So understanding from the patient, how does the breathlessness affect me? What can I do? What can I not do? Will help us to see whether any of our interventions are actually working for the patient or not. Helping the patient develop an awareness of the breathing pattern. Do they even understand what breathing in and out is, using their abdominal muscles, using their thoracic muscles? Teaching them pacing and positioning. How does a patient's behavior, how is it their behavior? They want to go to the bathroom. Do they get up and go as soon as they feel the impulse to go to the bathroom? Or they say, oh my God, I'm going to get breathless by the time I get to the bathroom. Let me wait. Then when it becomes very urgent, they'll get up to go. Then they'll be in tension that, oh my God, I might not make it because I might wet myself. So this entire process, it's a lot of behavior change that they're looking at over here. Handheld fans are an extremely useful and extremely underutilized tool. So a simple handheld battery operated fan, small little fan with 3 blades held about 10 inches away from the face, blowing air straight at the face will help stimulate the trigeminal nerve, will send a signal to our brain, helping us to slow down our breathing and reducing the sensation of anticipatory breathlessness and acute breathlessness. Distraction and relaxation, asking a patient if they already have a practice. If a patient has a habit of chanting prayers, if a patient has a habit of performing a type of exercise, if a patient has a habit of playing a board game, a card game, listening to some kind of music, I will try to incorporate what their practices already are into the regimen that I suggest for them for distraction and relaxation while we are waiting for medications to work when they have an acute breathlessness. And exercise and pulmonary rehab is an ongoing thing to help the patients maintain their levels of activity, remain strong while they are dealing with a chronic disease. So the research group at Cambridge, which is Professor Anna Spatis and Sarah Booth, devised this really beautiful model which works anywhere in the world. So they look at breathlessness in 3 domains. One is the breathing, one is thinking, one is functioning. And they say that a patient who has a chronic respiratory disease ends up developing certain maladaptive, patterns of breathing and thinking and functioning. So because I am breathless, I have anxiety and I tend to breathe huff puff fast, thinking I'm not getting air. So I will be like, but that actually makes things worse. So we want to teach them, and that's an inefficient way of breathing. So we want to teach them how to do consciously pursed lip breathing when they are perfectly well, breathing in a rectangle when they are perfectly well, where they just focus on breathing out. Inspiration is an automatic activity, but just helping them focus on practicing pursed lip breathing while they are normal, while they are not breathless, so that they're able to practice that same technique which has been taught to them when they have an acute episode of breathlessness. Thinking, what happens in our mind when we get breathless? It's like, oh my God, I'm getting worse. Oh my God, why is this happening? Oh my God, I'm doing everything right, but still things are not okay. Why is this happening to me? And then the thought that comes in people's mind when you're very breathless is, I'm going to die. What will happen to my family? Or if you've been hospitalized before, oh no, I don't want to go to hospital again. So this is a vicious cycle which will make them even more anxious, which will make them even more tachycardic, hypoxic, and even more breathless. So we teach them how to chant to themselves that this has happened to me before. I know how to breathe normally. I know how to do my pursed lip breathing exercise. I know how to break this cycle of acute breathlessness. It has happened to me before. I've gotten better before. I can do it again. So allowing them to use these chants, prompts in ways so that they can break that cycle of thinking which leads them into a negative spiral. When it comes to functioning, it's, as I was saying, that patients tend to isolate themselves. So they're breathless, they reduce their activity. Because they reduce their activity, because they get isolated, their muscles get weaker. Their muscles are weaker, then minimal activity makes them more breathless. So encouraging them to do activity with pacing, using any kind of assistance, a cane, a walker, a rollator, but keep them moving and active and doing their exercise. These are the 3 pillars on which breathlessness support services work. So teaching them the right positions when they get acutely breathless, to find a position of a relaxed sitting or leaning on the back of a chair so that your belly comes forward a little bit. Or if you're walking and you're suddenly breathless, find the wall, lean against the wall, putting your arms on a table and leaning your head down on it, lying on the side. For some people, lying on the back is not comfortable. So finding a side lying position, whichever side that might be, left or right, finding that position of comfort. It's important that we distinguish wheezing from stridor. Wheezing is an expiratory difficulty initially for most patients. Of course, in very acute spasm, then they may experience inspiratory as well as expiratory. What typically happens is people will use bronchodilators, inhalers, or nebulizers. Here, I want to say that if patient is not acutely breathless, an inhaler or a nebulizer works just fine, as long as they are able to coordinate their breath, inhale, and be able to hold their breath for a few seconds. If they are not able to hold their breath, if they're acutely breathless, then they will benefit more from a nebulizer. Theophyllenes, I've put in that word over here right up on top to have a small discussion that theophyllenes are not indicated for most patients. For COPD, for asthma, the deriphyllin, theophylline, doxophylline, acebrophylline, these are the last choices, but I still see them a lot in use. So please question the use of theophyllenes when you see it being prescribed freely. They are the last drug of choice. They are associated with more side effects, more cardiac dysarrhythmias, and therefore should only be used on patients who are optimally on the right bronchodilator, optimally on steroids, optimally volume statins, diuretics have been given. Stridor, which is an inspiratory sound of that kind of a sound, it's an inspiratory sound. is an indication of airway obstruction or dynamic airway collapse when there's tracheomalacia, things like that. The way it is treated is by giving bronchodilators and also getting a CT done to assess if there is an airway obstruction, and that patient will likely need an intervention either of a tumor debulking or a stent placement. If it's dynamic airway obstruction, these patients will also benefit from BiPAP or NIV. So these are the different types of masks and delivery systems that we use. We can use the inhaler with a spacer device to deliver the medication better. We can use a face mask as well as a mouth held nebulizer. So some patients feel very claustrophobic, and you'll find a patient with COPD who's trying to pull their nebulizer mask off. So maybe that person is feeling very crowded and claustrophobic. I told you that a fan helps the person not feel as breathless. So if you're wearing a face mask which has moist mist, which is static on your face, it might make you feel more crowded, more suffocated. So that same patient could use a mouth held nebulizer. So they're receiving the drug, but it also allows the fan to blow air on their face. So that's an important thing to keep in mind, the preference of the patient on a mouth held nebulizer versus a face mask. Oxygen delivery systems, multiple nasal cannula, venturies, non-rebreather masks, an important tool when you want to deliver 10 to 15 liters higher flows of oxygen. Of course, nowadays we also have high flow nasal cannula. In most places, that's only available in the ICU, but it's a far more comfortable way of delivering very high flows of oxygen to the range of 50 to 60 liters per minute for patients who have acute respiratory failure. When patients have a high PCO2, we need to keep in mind that they should not be given high flow oxygen. The goal here is to just keep a saturation above 90 or around 92%. So we don't want to see 96, 97% there because we don't want them to retain carbon dioxide. These patients are better suited to be discharged home on oxygen, may need oxygen at home, and they will need support in obtaining oxygen concentrators or portable oxygen units. If they have a long length tubing, then that will allow them to be mobile at home. See, what happens is we prescribe oxygen, but the tubing is only 4 feet long, then that patient is not going to exercise. So we have to tell them to get a long tubing so that they can walk around in the room. Some patients look at oxygen as a stigma. Ayo, I don't want to go out with that thing on my nose. What will people say? So we have to help them develop an attitude where the oxygen is something which is not a marker of disability. The oxygen is a marker of improving your ability. If you want to be more active, be able to go and do the things you like doing, you like going for meetings with the ladies in your building, you like to go out and have coffee with your friends, you like to go out and sit in the park, then the portable oxygen is a way of maintaining your ability. So it's not a marker of disability, it's a marker of improved ability. Tracheostomy is sometimes required for patients who have recurrent aspiration pneumonia, especially Parkinson's patients, ALS patients who have difficulties with swallowing. And that's something that we also need to, help the patients first understand what the limitations in their life will be with the tracheostomy, and also help caregivers to take care of the tracheostomy, the change of the inner cannula, what to do if a tracheostomy tube gets blocked, etc. Cough is a very troublesome symptom. It's the second most common symptom that people present to any clinic with. Very difficult to treat as well at times. I see an overprescription of cough syrups. The majority of cough syrups really don't do anything. 85% of the effect of cough syrups is a placebo effect. So cough syrups, again, I use very less. I take a careful history to understand, is it airway disease? Is it bronchiectasis? Is it interstitial lung disease? Is there acid reflux? Does the patient have a nasal condition with, post-nasal drip, and do they need a nasal spray? For the kind of patients who have chronic cough, especially the ones who have interstitial lung disease, it's a very distressing symptom, hacking cough, dry cough. It makes them exhausted, and they can even get fractures in their ribs from severe bouts of coughing. Women suffer from stress urinary incontinence. So your quality of life is really terrible when you have chronic cough. So it's important that we give them the right agents to take care of the cough. Some of the simplest agents are demulcents. So the lozenges, Alex, Tuscu, anything which has some dextromethorphan in it, even the standard strepsils, cough sils. The idea is something sticky, thickened honey consistency. Our grandmothers used to give us honey with turmeric. The main action over there is in creating a protective film which has a higher viscosity on the back of the throat, and that calms down the irritation that the nerve endings are feeling at the back of the throat. For their patients develop a cough hypersensitivity. The smallest little trigger will make them cough. So neuromodulators like opioids, baclofen, gabapentin in low doses, gabapentin 100 milligrams, speech therapy, where especially for patients with chronic ILD, speech therapy, speech language therapy helps a lot in suppressing that persistent cough that comes. Secretions, another important thing to keep in mind, we look at whether they are oral secretions or tracheobronchial secretions. Is the patient having more secretions because they are fluid overloaded? So understanding whether there is volume overload, the patients in heart failure, do they need Lasix? If there's airway obstruction, do they need steroids? And looking at the quality of the secretions, right? When did the secretion start? What makes it worse? What reduces it? Is it clear? Is it white? Is it yellowish? Is it greenish? Is there some blood admixed in it? Where are you feeling the secretions are more? Is it in the throat, or is it in the lower part of the chest? Is it in the nose? The severity and understanding the value systems of the patients over here is understanding, and values is especially in situations like bronchiectasis, where they develop colonization with bacteria and there is foul smell that comes from it. These patients feel very isolated. There is a lot of depression that comes along with halitosis, with retained secretions and stuck secretions in bronchiectasis. When I say understanding the value system, that's understanding in patients with neuromuscular disorders, that is secretion management and aspiration something which wants them to consider the pathway of tracheostomy and PEG, or is the patient's value system one where they say they do not want invasive procedures like tracheostomy and PEG? It's always the patient's preference. Accordingly, you have to tell them the pros and cons, and then once they do it, teach them how to manage that equipment accordingly. We do use certain devices to help clear secretions. In the hospital setup, there are certain types of cough assist devices that are available. In the outpatient setup for patients with bronchiectasis, we use mucus clearance devices. When patients are at the end of life, very often they cannot manage as their mental status goes down. There is very loud breathing. So this term death rattle has been used in the past. It is highly urged to not use the term death rattle. We call it noisy upper airway secretions right now. You don't have to treat noisy upper airway secretions unless it is interfering in the patient's comfort or causing more breathlessness. So if the patient's saturation, especially this is an end of life situation, we don't care about the saturation in end of life care. We do care if the patient is troubled by it, if it's worsening their cough, if their face shows distress. If that's the situation, I will give the antimuscarinics and things like that to help reduce the secretions. If it is not causing any of that, I will counsel the family and tell them, don't worry, that sounds terrible to you, but the patient is not in any discomfort because of it. Some patients with neuromuscular disorders, when they end up having retained secretions, you might have a mild fever, you might have a urinary tract infection. This is a patient who is on a tracheostomy for ALS or something like that. At that time, their muscle strength goes down just temporarily, and they end up having a lobar collapse or something. At that time, it is perfectly okay to proceed, if need be, with a bronchoscopy just to clear out that space, allow for more clearance of secretions, and also help them to recover from that acute infection that they are going through. Of course, that's not something that one does repeatedly or offers when it comes to end of life care, because at that point, it doesn't offer more benefit. Postural drainage is a very important nursing at the bedside, physiotherapy at the bedside measure, especially for patients who have destruction in their lung architecture due to long-standing tuberculosis, bronchiectasis, post-viral bronchiectasis, allergic bronchopulmonary aspergillosis, many conditions where they are not able to drain out secretions in certain areas of the lung. So we teach the family members how to use mucolytics, bronchodilator nebulizations, and assume positions which will facilitate clearance of secretions. Teach a family member how to do chest PT percussion and help them to clear secretions twice a day if possible. So this will prevent recurrent exacerbations from being as frequent. These are the cough assist devices that I spoke to you about. The cough assist device vest is not available in India, but we do have mucus clearance devices. What you see below in the blue and the green is what's called a shaker deluxe and a power and an a cappella device, which helps to clear secretions in patients with bronchiectasis, very useful in these patients. More devices and aids, a step counter to help patients keep track of, whether they're, how many steps are they walking every day, a handheld fan, which will help them relieve the breathlessness, a walker with wheels, so that will help them to move around in the house a little more and have that support for them as they walk. They're not afraid of falling then. A gel pad mask on the nose for patients who need chronic BiPAP use. They sometimes develop nasal bridge ulcer. So these are the little things that we can do to help them be more comfortable with the devices and machines that they have to use. Hemoptysis, very distressing symptom. Standard of care is to give cough suppression, stop all nebulization. The patient should not receive nebulization because that causes more cough to happen. The bronchodilation will be followed by cough. We want to suppress all cough. So we give cough suppression with codeine or dextromethorphan or any other low dose opiate. We give tranexamic acid to reduce the hemoptysis. We might give mild sedation if the patient is extremely anxious. Sometimes they cough up a large volume of blood. It is very distressing. They might be anxious, so you might give mild sedation. Further intervention is according to the goals of care. So if we think this patient is acutely ill because of a condition which is potentially reversible, then this patient may be sent for further intervention like a bronchial artery embolization or a bronchoscopy. However, if this is a patient who has had this happen many times and this was anticipated and the plan of care is to provide comfort or supportive care, then at that time we continue with the sedation, anxiolytic opioids, the tranexamic acid, and we make sure that we definitely try and do something simple like using dark color linens, so the patient is not distressed by the sight of their white bed sheets and bedclothes completely colored with blood. Very distressing for patient and caregiver. So just use of dark linens is a simple, thoughtful way of reducing the anxiety and distress to the patient. Pleural effusions may come up in many conditions, whether they are from the lung or from other areas as well. So for example, you might have a malignant pleural effusion in anything which metastasizes to the lung. You can have recurrent pleural effusions, non-malignant pleural effusions with cardiac disease, with end-stage heart failure, with end-stage liver disease, with end-stage kidney disease. The way we manage these effusions is initially it's about optimizing the treatment of the underlying conditions, but then it becomes recurrent. We will either offer an indwelling pleural catheter called a Pleurex catheter, or we can offer pleurodesis, which can be done to prevent recurrence. This is a palliative procedure to prevent refilling as much as possible. Aspiration pneumonia, we spoke about neuromuscular disease. There are clear indications if there is a drop in lung function to plan for tracheostomy or PEG. Accordingly, they need to be counseled that it will not eliminate it, but it reduces the chances of it. And if the family so chooses, if the patient so chooses, then it's ideal to do it before the patient becomes malnourished, so that you're really improving their chances of retaining as much strength and preventing recurrent infections. We always should have a plan for our patients for what to do when they have an acute emergency. If they have a tracheostomy, how does a patient and family member respond if there is a block of the tracheostomy tube? If a patient is on oxygen or on BiPAP at home, what to do if the saturation drops? What to do if the patient suddenly chokes on their food while they're eating? What to do if there is a sudden drowsiness and the patient's not breathing? What is the plan in each time? So this is something when a patient is being discharged from the hospital, what to do if this happens again? Are we coming back to the hospital? Are we choosing comfort care at home? If we are coming back to the hospital, is everything okay to go to ICU, to go to ventilator, or are we putting goals of care where we say this much and no further? So that needs to be discussed with the patient and family member, value their opinion and their choices in this. Patients with chronic respiratory disease eventually start losing weight, they become cachexic. When this happens, we know that that's a bad prognosticator. They may not survive beyond a year. We always encourage them to maintain their nutrition with a high protein, low carbohydrate diet. If the patient has signs of right heart failure, then we tell them to restrict their fluids to not more than 1.25 liters in a day. When patients start dropping weight initially, it is worthwhile to give a trial, especially for patients with COPD. This has been proven with multiple studies that decadurabolin with a high protein diet, given as a 3-month, once in 4 weeks dosage given over 3 months, as a cycle in once in 6 months is doable. Appetite stimulants, not much evidence, though it can be tried to help them to encourage them to eat more. Patients have a lot of GI symptoms. We make sure that they are on anti-reflux and prokinetic measures. They have bloating because they swallow a lot more air, so simethicone can be helpful. Constipation, a sensation of dry mouth, symptomatic treatment for these is what is suggested. Chronic pain, a lot of patients with COPD and ILD have pain because you noticed how much harder you had to work to breathe at the end of your expiration and at the top of your inspiration. So these patients also develop muscle spasm, things like that. And opioids, especially in patients with low oxygen level. The fact is, this is to be treated in the same way as treat pain in any other situation. You work your way up the WHO pain ladder. If we have to use opioids, we start low and go slow and always give a bowel regimen along with it. If the patient has excessive drowsiness, we cut back the dose and we use as much of non-pharmacotherapy, ultrasound, TENS, IFT, all of those methods can be used for addressing the pain that patients experience. The use of oxygen NIV is disturbing because those machines, so at night those machines make sound. So this requires counseling, helping patients to cope with and adjust to these devices. Melatonin is safe and can be used. That's the drug of choice that we start with for patients with sleep disturbances who have COPD, who need to use oxygen or NIV. However, low doses of benzodiazepines, anxiolytics can be used if there is really disturbed sleep. Again, we try to use in combination with non-pharmacological therapy. TB, I just want to put in a word. India has a prolonged with drugs which are known to cause, along with that, the isolation and the stigma associated with it. Our National TB Elimination Program and previously the National TB Control Program that was there just make a mention of palliative care, but there are no clear guidelines. We are in the process of putting together a think tank to come up with, as much evidence-based guidelines as we can for this. So we need to keep counseling the patient and family, encourage them and address the patient's worries to ensure adherence and completion of the treatment until they become sputum negative and no longer at an infection risk to community. Health-related quality of life is what we have to address in chronic respiratory disease, not a CT scan, not a saturation, not an FEV1. So trying to make sure that we address the breathlessness, the cough, in a way that the patient is able to achieve their personal and professional goals, whatever it may be, their role in a family. Very often we find that caregivers take away all the work of a patient. I don't want my mother to work in the kitchen, she'll get exhausted. At least let her sit in front of the TV on oxygen and chop vegetables. She'll feel like she's contributing. So a person's sense of having some satisfaction that I am useful to the people that I live with, that I love, my role in the family is maintained. So you have to always help the family members understand that they need to be encouraged to be active with a sense of purpose. We tend to have opioid phobia as clinicians, as healthcare professionals. We need to get over it by reading and learning more about it, how to use it safely. For refractory breathlessness, low dose sustained release morphine is safe to use. There are multiple studies about it. It's hard to come by sustained release morphine, and there is some new evidence saying that immediate relief will be as effective or maybe even safer to use than sustained release. If you have any doubts about it, you can always use immediate relief. We use it in the doses of 2.5 to 5 milligrams orally every 6 hours or so. And you can even use it just less than every 6 hours. Most of our patients, they are opioid naive. So when they start off, that one dose that you give them at night allows their breathlessness to be alleviated to a degree that they sleep very well through the night. That allows them to be more active with their pulmonary rehab in the day. And that itself helps them to reduce their breathlessness overall. Always to give it with a bowel regimen. What about end of life discussions? So I spoke about how cachexia, weight loss, is a poor prognosticator. So the surprise question is something that, would you be surprised? You've been seeing a patient in clinic for 2-3 years, and then if someone asks you, would you be surprised if this patient didn't make it past this year? You ask an experienced nurse, an experienced respiratory therapist, an experienced clinician, would you be surprised? And if they say no, I don't think that person has more time, that is one of the most accurate prognosticators that this patient is declining. So if a patient has a low FEV1, if they have become dependent on oxygen, if they've had 2 hospitalizations in the last 1 year, if they have other medical problems, they also have heart failure, they're not able to move around, they need assistance for every little activity, and they have, as I mentioned, weight loss, and their age is on the higher side. These are patients where we should discuss about end of life, right? So especially if they've had an ICU hospitalization, one should think of their preferences. What about life-sustaining treatment? What about ventilation? What about dialysis? What if the next time they come sick or even sicker than they are this time? So that's something that we need to look at. Simply, we should ask the patient the goals of care and ask them, if you think it's an awkward question, think, have you ever thought what to do if the disease gets worse? What matters to you most in life? If some people will say, what matters to me is I shouldn't trouble anybody, nobody should trouble me. Have any of your friends or relatives been through a serious illness? Last time you were in ICU, what was that experience like for you? When they tell you it was horrible, I was all alone, things like that. So you have to look at questions which will allow you to explore their thoughts and preferences about where they would want the end of life to be. And always, since the caregiver has to do a lot for patients with chronic respiratory disease, they have to manage oxygen, nebulization, BiPAP, take their patient for all these visits. Very often, patients will tell you over time, because their activity decreases, they're like, how are you doing? They'll say, I'm okay. When you ask the caregiver is looking frazzled because that person's work in the last 2 years has increased. They started off with giving nebulizations 3 times a day. Now they are giving nebulizations multiple times a day. They are connecting oxygen at some time. They're connecting BiPAP at some time. They are getting exercises done at some time. They're getting incentive spirometry done at some time. They have to make a separate diet for the patient. So that person will tell you, my burden is increasing. That's actually telling you this person is needing more and more support for everything. So the perception of a patient may not always match up to what's happening. So you should always look at it from both the patient and the caregiver's perspective to recognize when is the disease decline accelerating. And we teach the patients patient's caregiver how to have a backup plan. They're going to be on devices like a BiPAP or oxygen concentrator, and they need backup electricity. What if there's power failure for 6 hours, right? And so caregivers go through a lot of difficulty. They also go through health problems. We should always keep our eye on the caregiver and support them as much as we can as well. And after the death of the patient, or when the patient is critically ill, even before the patient is critically ill, I always like to, reach out to the family members and appreciate the amount of time and energy they spend to take care of their loved ones, saying, you're doing such a good job of taking care of mom, you're doing such a good job of taking care of your partner. That little word of support really helps them a lot in continuing with taking good care of their patients. So what I'd like you to do now to join me again in a quick breathing exercise. So again, I'd like you to find a comfortable seated position. Raise your shoulders up close to your ears and drop them back gently. Find a relaxed position. Move your head very slowly from side to side. Ease out the tension in your neck. And then take a long breath in. Inhale and exhale all the way out. Another breath in. And as you exhale, close your eyes gently. Continue to take slow, easy breath in and out at a pace that is comfortable to you. Bring your attention to your breath. If you like, you can count with the breath. 1 as you breathe in, 2 as you breathe out, 3 as you breathe in, 4 as you breathe out. Just keep your attention on the breath. Now, I'd like you to picture a scene of a place that is close to you in your heart. It could be a place which is near a mountain, near the beach. Maybe there's a water body where you are. Imagine the color of the sky there. Imagine that you can feel the breeze on your face. Imagine that you can smell the salty air of the sea. Bring your attention to the sound of the water. You can hear the tinkling sound of the water, the waves, the stream as it passes over rocks. Now slowly bring your attention back to your breath. Deep inhale in, exhale out. Deep inhale in. As you exhale out, open your eyes gently again. And you realize that you have your breath as a tool to help you find a few minutes of calm and comfort every day. So this is an exercise we can try and teach our patients, even the ones who are breathless, who have to breathe fast. But visualization, being able to relax their muscle, helps them to overcome moments of breathlessness. I hope you found that useful, and I'm open for questions and the case discussion that is to follow.
I want to ask one question.
Sure.
Ma'am, you said caregivers are told to do BiPAP, take care of BiPAP, then nebulization. So, what is the actual minimum qualification of a person who's a caregiver who can give BiPAP to a serious patient?
The minimum qualification is that they should be able to use a check for a leak and be able to position the patient. So there's no educational qualification that they need. You know, we can teach
Means you can
anybody
give
who has
BiPAP at
education.
home.
Yes, doctor. We do prescribe patients BiPAP at home. There are many patients who are on BiPAP at home for years. This is that we, have home care nurses who train them.
Excuse me, ma'am. Madam, your voice is breaking in between. Actually, we couldn't hear.
Okay, I said that there's no minimum education qualification for the caregiver. Anyone who can be taught how to fit mask over the BiPAP mask over the nose and mouth, and check for the straps being tight enough, check for an air leak with their hands. Anyone who is an above a teenage age, I guess. You can't be a child taking care of a person with NIV. That's really where it's at. I've had patients who are being taken care of by their 14-year-old granddaughter, and taken care of very well. Tune in to, okay, if the patient is vomiting, don't put the BiPAP on. If the patient is drowsy, don't put the BiPAP on. They just need to be able to follow instructions, and you teach them the do's and don'ts and when to put the BiPAP on and when to take the BiPAP off. It's as simple as that. Because we make the settings on the machine and they just go home and put the straps on, take it off for the duration that we advise them to use it. Shall we move to the case discussion?
Yes, ma'am. Actually, thank you so much, ma'am. It was a knowledgeable session. I hope everyone has got a new idea about palliative care and respiratory system. And we used to come across many symptoms commonly, most commonly, breathlessness, hemoptysis, stridor, death rattle, etc. And I know you all have many doubts to ask. Actually, we can have case presentation now. Today, Dr. Hairuniza from Calicut, who have completed medical MBBS and currently working in clinic, Pioli Clinic, Calicut. She's with us with presentation. Over to you, doctor.
Good evening, all. Am I audible?
Yes, you are audible, doctor. You can continue.
Okay. I'm Dr. Hairunisa, working at Chingakuram Clinic in my native place. Today I'm with case presentation of a 66-year-old male who was diagnosed with carcinoma right lung with sternal metastasis and mediastinal lymph node involvement. His cancer is now at stage 4. Next slide. Presenting complaints. He was presented with exacerbation of breathlessness since 10 days, exacerbation of cough since 10 days, and bone pain, that is of sternum, and disturbed sleep, reduced appetite. Next slide. History of illness. The patient, while working abroad, got admitted with breathlessness and cough in December 2021. He was provisionally diagnosed with some lung disease from abroad. Due to high expense there, he left abroad and came to his native place for further investigations and treatment. From MVR Cancer Center and Research Institute at Calicut, he was diagnosed with squamous cell carcinoma of right lung on March 3rd, 2022. Then he had 8 cycles of chemotherapy. After chemotherapy, his condition was improved, but afterwards he got sternal metastasis, for which he received 20 gray in 5 fractions of radiotherapy on 11th of on 4/11/2022. He gradually became weak after radiotherapy. Okay, then he had chronic dry cough and breathlessness for the last 10 months, which now exacerbated since last 10 days, along with disturbed sleep, sternal pain, and reduced appetite. Breathlessness is more while walking and on laying in bed. Cough is intermittent, non-productive, and more while laying on bed and at night. His sleep is affected that he sits in a chair and sleep for the last 10 days. And all the symptoms were not associated with vomiting of blood, constipation, hoarseness of voice, urinary leakage, abdominal pain, or altered sensorium. He was a chronic smoker for last 40 years, and he stopped smoking after he got diagnosed with the carcinoma. Next slide, please. Examination findings. Generally, the patient was conscious and oriented. There was pallor, no visible lymph nodes, cyanosis, or clubbing, and his temperature was 98.4 degree Fahrenheit. BP was slightly below normal, 90/70 millimeter of mercury, and pulse rate, SpO2, and other findings were normal. Respiratory system examination. On inspection, the patient was sitting in a chair, and there was a wound of radiation therapy over sternum. The wound was fully red colored, and there was oozing and foul smell was also there. Respiratory rate is 24. On palpation, Trachea slightly deviated to left side. Tenderness was present near the radiation site, and patient was not cooperative for more examination due to his pain. And percussion was not done. And auscultation, scattered mild crackles was there on right side, mainly on posterior aspect. And other systems were within normal limits. Treatment and significant investigations. On blood routine, hemoglobin was 10 gram per deciliter. Other findings were within normal limits. And on histopathology report, he was found to have squamous cell carcinoma. And on CT thorax, there was heterogeneously enhancing speculated lesion in posterior segment of right upper lobe with evidence of chest wall invasion. Bulky mediastinal lymph node was there. Emphysematous changes in lung parenchyma. And also PET or CT study was also done, which found out to be the same. Treatment, he underwent 8 cycles of chemotherapy, then 20 grain 5 fractions of radiotherapy. Then the day before which when I took the case, he was given injection Dexona 16 milligram IV stat, and he is now on Ultracet, which is a combination of paracetamol and tramadol, then pregabalin, amitriptyline, deflazacort for his breathing difficulty, also for the breathing difficulty, Levogen and Folate for his anemia correction, and for the dry cough, which he presented, he was on Tapnos, which is 25 milligram BD, and Montecalci, which is a combination of montelukast and levocetirizine, Moxican CD, and Pandop, and the radiation wound is cleaned with normal saline and metronidazole tablet, which was crushed and applied over the wound. Next slide, please. And psychosocial aspects. 66-year-old man whose wife also suffering from certain illnesses is taking care of him with some supportive help from neighbors. Breathlessness and cough makes him difficult in interacting with others at certain times, and his sleep was totally disturbed, mainly for the last 10 days. Among 2 sons he had, one committed suicide at the age of 34 due to his business losses and depression, and his wife, that is his elder son's wife, was then married to another man. The other son, who was a taxi driver abroad, was jailed 1 year back due to some issues there. And his mother is saying he will only get released after 5 years. His wife, who's a nurse and working abroad, and her salary is the main source of income with which this family is now doing their every activities. The patient says, why all problems are there for my family? We have not done much sins to punish like this. And I wish to die as early as possible. And I want to see my son before I die. Next slide, please. Main concern here, the patient is with terminal stage of cancer and breathlessness and cough, making distraction in interactions, and his sleep disturbance, lack of interest in life, and wife who's taking care of him is also suffering from illnesses, meeting his son, and financial problems, and wound of radiation therapy. Summary. 66-year-old man who was a chronic smoker and with chronic cough and breathlessness before 1 year was diagnosed with squamous cell carcinoma for right lung before 9 months, and later on with sternal metastasis and mediastinal lymph nodes involvement. He underwent 8 cycles chemotherapy, radiotherapy for the sternal metastasis. Now complaints of exacerbated breathlessness and cough, sleep disturbance, pain and foul smell over the radiation site, and also reduced appetite. Discussion points: how to address his problems, mainly breathlessness, cough, wound pain, and discharge from the wound. what all can be done for his wife and family.
Thank you, Dr. Harunisa.
Okay, thank you.
I think now any doubts can be asked and along with the discussion points. First discussion point is how to address his problems like breathlessness, cough, wound pain, discharge from the wound. Anyone can unmute and answer. What are the main concerns? You have already seen the case presentation. So anyone, just brief up what are the palliative factors we can optimize for this patient.
So maybe I'll jump in here since people are taking a few minutes. We did discuss with breathlessness that there's one part of it which is optimizing the pharmacological treatment, and then we go to all the non-pharmacological aspects, right? And Dr. Ironisa has told you that on his treatment, you are seeing steroids, you are seeing bronchodilators and all of that. He's not had any hemoptysis, so that's fine. So essentially, he is on all the optimal medications, right? So now we have to look at all the non-pharmacological means that we can help him for his breathlessness. And what would those be?
Okay.
Using a handheld fan,
Yes.
a moist cloth over the face. So you just take a handkerchief, moisten it with some water, wipe it over the face, and then use a fan, a handheld fan or a table fan which blows air straight at his face. Ensure that he's on oxygen. His saturations are running a little low, around 92. So maybe a little bit of supplemental oxygen may help him. You first try the air because at 92, he's not too low. So just the air might help him with the breathlessness. Teaching him pursed lip breathing and pacing, just to do simple things like moving in bed, right? When he wants to change position, when he wants to sit up, teaching him those exercises of how to breathe better. That will help. Asking him what are the thoughts that come to his mind. He did say about, the concerns that come in his mind. So if one can find certain chants and thoughts that help him to overcome those episodes of breathlessness. So the non-pharmacological means is what we will be looking at for his breathlessness. And if that doesn't help, he's on Ultracet, which is tramadol and paracetamol. So maybe the next thing that we want to think of is morphine itself. Low dose immediate release morphine for him, right? Where his cough is concerned, he's already on a pregabalin.
Hello, ma'am. Sorry to
Right?
interrupt you. Tramadol and
Sure.
morphine cannot be given together.
Right. So you'd have to discontinue the tramadol and then use only the morphine that would work for his breathlessness as well as his pain. The tramadol is not helping his pain, not helping his cough, and it is not going to help his cough. So that's why it either needs to be codeine or morphine when we are looking at breathlessness. Now, what happens when you have a patient with pain as well as breathlessness is we use, say a patient is already on morphine and is also breathless, but their pain is optimally managed. You only need 10% to 15% more of that morphine dose to address breathlessness. So this is where you might need to change the agent in this patient for pain. Because the morphine, a low dose morphine will help his breathlessness as well as his pain. Okay. That's to consider in this situation, as long as you don't have any other contraindication.
Excuse me, ma'am. Your voice is again breaking down.
Okay. So as I said, the thing to consider for him is whether you would want to change the pain agent to a low dose of morphine instead, because that will help him with his pain as well as his breathlessness, as well as the cough. So you 3 birds with 1 stone.
Also, we
As
can,
I said, we tend to
mhm.
we tend to prioritize pain over cough and breathlessness, right? The same thing that I was saying earlier. Patients with breathlessness do not have their breathlessness addressed. So if we choose an agent which can help his pain, breathlessness, and cough, that would be morphine, not the tramadol.
Okay, ma'am.
Good evening, ma'am. Can you, hello?
Yes, yes, Dr. Priyanka, you can ask.
Yeah, ma'am, can you please tell me what are the different
Yes.
kinds of preparations of codeine that we can use for cough suppression or for the treatment of cough?
So, unfortunately, codeine has become harder to obtain. We used to use either syrup linctus codeine or tablet codeine, which used to be available in 15 and 30 milligrams. So, that's usually the kind of dosing that one would give for cough suppression. 15 to 30 milligrams every 6 hours or so is what one could give. Um, Again, since it's harder to get if you have access to morphine, the doses that we use for breathlessness and for cough are really small doses. 2.5 to 5 milligrams every 6 hours or even every 8 hours is where you will start with. So you'd have to, for this patient, find the low dose of morphine that works for their pain as well as their breathlessness and cough. Normally, the dose that will control the pain, you need just 10% more of that for the breathlessness. This patient, since his pain seems adequately controlled with tramadol, most likely the low dose of morphine that you need for pain management will also help automatically to control breathlessness.
Ma'am, one thing more. For example, if a patient is already on maybe low dose morphine for his pain suppression, maybe 5 mg 4 hourly or so, in that case, for example, a patient is having refractory cough also. Like they've tried the other approaches, but it's not working. In that scenario, should we like try to increase the dose of morphine to handle the cough, or should we just restrict to
The
some other
most
approaches
important
only?
thing here is to find out, again, if we go back to cough, it was to figure out what is causing the cough, right? So if it is secretions which are the problem, then we look at secretions. If it is acid reflux and bloating which is the problem, then we look at that. If we've solved all of those problems and it purely comes to, say, something like a patient who has lymphangitic carcinomatosis spread all over the lungs and they are having an irritating cough because of that, you have two options there. One is to look at whether you can adjust the dose of the neuromodulator, like a gabapentin or a pregabalin, if you have room over there to increase that. That decreases the cough hypersensitivity. Or you could choose to increase the dose of morphine by about 10%, typically looking at either just the morning dose and the night dose to help you with the cough and breathlessness suppression.
Okay.
Okay, thank you so much, ma'am.
Thank you, ma'am. I think it's clear for all of you how to manage breathlessness, cough, and wound pain. Now the patient is on tramadol, as ma'am said, starting with morphine in low dose. After stopping tramadol, as Dr. Nandini has mentioned, we will not continue tramadol and morphine. Both we will not continue. We will stop one medicine, one opioid, and we will be giving morphine alone. Okay, in low dose we will start, and according to the pain status, we should follow up the patient, and according to that, we should modulate the medicines. Okay, and regarding
Oh,
the
let's also not forget we were also going to get the fan and the breathing exercises and
yes,
all of that first.
yes,
Then
ma'am.
we would get after that would come the morphine. Yeah. Yeah.
Yes, yes. Both pharmacological and non-pharmacological measures should be covered in all the symptoms. First thing, as ma'am already said, we should look for what is the main cause of breathlessness or cough or anything. Okay. Then regarding the discharge from the wound, we have another session how in wound management, and in this case presentation also the wound scenario is not covering the description of the wound, and it's not mentioned, and we have another session how to manage the wound. So in that session we will cover that, and what all can be done for his family and his wife and this patient. itself. Anyone can unmute and answer, and then we will like to hear from Madam, Dr. Rajani, Madam as well. Usually you all unmute and answer and make it very interactive. I don't know what happened today. We have already seen the similar scenarios in previous sessions. In previous sessions, in every case presentation, we used to have this question. So I think it's clear for all of you. But anyone, please unmute and answer.
Just pitching in, being a very non-medical person, I myself can imagine, like when one of your son is gone and the other son who was the breadwinner in the family is in jail in another country, and your wife is also having illness. So I believe these are the basic reasons for his sleeplessness, because even we can imagine, right, when we are overstressed, just because of professional overburdens as well, we find it very difficult to sleep as during the normal days.
Yes. Sri Priya has covered all the points, psychosocial aspects. I'm so surprised and so happy to hear from you. Why? Because she is not in clinical team, but I got a very good response from her. So anything we missed, you can add up. What all can be done? She has raised the main concern of the patient and how it can be managed. What are all the things we should do for this patient? Just brief up in few sentences. Then we will go to further questions, if any. Yes, we should utilize this session. Why? Because we have one of the most eminent faculty, and she can guide us in the session very clearly. And we used to come across many scenarios and many symptoms in both cancer and non-cancer cases. We used to see this respiratory system is the symptoms are very common: breathlessness, desaturation. The patient in ICU setup, we will be mostly confused and all. So all of you might have experience. Definitely, you all have experience, and you might have doubts also. Now you have an opportunity to ask your doubts. So please come across with questions.
So we can talk with the patient about this problems what Sri Priya mentioned. The talking itself will relieve him, and psychological support, and we may involve some NGO in the situation, and may ask for some help, financial help to the family. I think this is the main concern, the financial aspect, as well as, the other problems, psychological. So the talking with the patient about the problem, psychological support, and involvement of an NGO. These are some main aspects we can involve.
Yes. Thank you, ma'am. Thank you.
May
And
I make
yes.
a little suggestion here as well?
Sure, ma'am. The floor is always yours, please.
Thank you. He says, I wish to die as early as possible, and I want to see my son before I die. So I think there is some unresolved guilt that's there. So the social worker or psychologist can help the patient address any unresolved guilt. And the one thing that we learned in our post-COVID world is the use of technology and video conferences and video calls on WhatsApp and things like that. So it's important to see what's the dynamic between this gentleman and his son who is in prison. Jyoti ji mentioned about incorporating the use of an NGO who might help to provide a connect. The patient's son is abroad in a prison there. Just that act, right, of being able to speak, if there is an apology to be made, if there is forgiveness to be sought or to be given, that will alleviate his pain and breathlessness a lot. So we can do a lot with that.
Yes, ma'am. As you have mentioned, we should hear from the patient, and we should explore psychosocial and psychological support, as well as the help from social worker and NGO if possible, and the new modalities also should be utilized. And in our chat, Dr. Dora Babu has mentioned communication, continuous communication to see that son and see as soon as possible that should be facilitated. And Ravi Shankar, Dr. Ravi Shankar has mentioned. Ma'am, can you please tell us about how to care patient with severe ILD where bronchodilators or lung expansion exercises are of less effective other than oxygen support? Dr. Rajani, madam, can you please take up that?
Sure. So this is one of the most challenging situations when you have patients with severe ILD. You're absolutely right. Bronchodilators are not of much help there. If anything, we only use short-acting bronchodilator for episodic breathlessness. Morphine is the one drug which is useful for episodic breathlessness in ILD. So in ILD patients, we don't give maintenance dose of sustained release morphine. It's only when they are about to do an activity or when they have an acute episode of breathlessness, we give small doses of immediate release morphine. You already mentioned oxygen. So progressive fibrosing ILD patients will receive oxygen, will receive antifibrotic agents, which will either be drugs like pirfenidone or nintedanib, which will be prescribed by pulmonologists who are seeing the patient. Occasionally, when they have acute worsening, then acute exacerbation of ILD, short courses of steroids can be useful. So maybe you'll give them steroids over a period of 5 to 10 days or something. So they get a burst of 5 days with a taper down gradually over 10 days or over 2 weeks. Using the fan is a very useful thing for patients with ILD. Most important is to start off on the rehab and exercises early in the diagnosis of ILD, teach them how to do the breathing techniques and pacing, right? So on a baseline level, you want them to be on maintenance drugs, which are appropriate, antifibrotics, oxygen, pulmonary rehab, diet, nutrition, all of that. When they have acute worsenings, short bursts of steroids, use of morphine SOS in acute worsening. Over time, they may require maintenance morphine, but the majority of ILD patients, when it comes to end of life care, are not on morphine for longer than 3 to 6 months at a time, and it's not been studied for longer stretches of time. The treatment of choice in patients with progressive fibrosing ILD is actually only lung transplantation. Unfortunately, that's available to very few people, very expensive, which even more makes it important that we understand and get comfortable with the use of low dose morphine, low dose benzodiazepines, low dose neuromodulatory agents like gabapentin to help relieve with the breathlessness and cough.
Thank you, ma'am. I think it's clear. And coming back to the case presentation,
just one last point I wanted to make here. ILD patients, if they land up in the ICU for end of life, instead of using BiPAP, and definitely should not be on ventilator if it's a known progressive ILD, high flow nasal cannula oxygen is a much better modality for end of life care in patients who have ILD, because it leaves the mouth free. They can still taste food, they can still speak to family. Even if the saturation is 60%, 50%, if they are on morphine and on high flow nasal cannula, they are comfortable enough to be talking to family literally until the very last hours. So for the bereavement, for the spousal bereavement, for the family caregiver bereavement, they are able to see and speak to their loved one and know that that person is not breathless if you use a combination cannula as well as the opioid.
Thank you, ma'am. And another point in chat by Dr. Dora Babu itself, psychosocial support for his family, even for his wife also. Yes, of course, doctor, we should hear from the caregivers as well. Both wife, actually the son, one son has gone, one is there in the jail, and that should also be another session should be communication session should be availed for them as well. And Dr. Mahrukh has mentioned for his wife and children same meeting with a social worker who can counsel them can be arranged. And another point, which I have already read. Dr. Babu has mentioned. And yes, as you all have mentioned, the psychosocial aspects should be covered along with the physical aspects. We should get the support from social workers, any psychologist, if any, we should get the support from them as well. We should provide them a vent out session for both patient as well as caregiver. When a patient is being admitted to our IP, we used to spend more than 1 to 1.5 hours with patients, making them to vent out. Okay, that itself can cause not cause, that itself can give some relief for the patient. Sometimes if the son is in the jail in another country, so we may not be able to bring him back and make him a direct contact with son, but we can hear from the patient what are his concerns, but and we should not give false hope at the same time, and but we should do the maximum whatever possible to give him relief in all ways. Okay, and apart from this case discussion, if any other doubt which you come across in your day-to-day practice, that can be also you can put up in chat or you can ask madam directly. We are running short of time actually. We can take 1 or 2 questions, any relevant questions which is not covered today, that can be taken up.
Good evening, ma'am.
Good
This
evening.
is Dr. Priyanka. Ma'am, this is not just related to the session as such, but I would just like to ask, is there going to be a session or a talk on the use of various psychotherapies in palliative care?
I think that's a question for the Pallium India team.
Sorry.
Yes, ma'am, actually.
Okay.
Hello.
Sorry, Dr. Priyanka, can you please repeat the question?
Yeah, sure. Ma'am, I just wanted to inquire, is there going to be a session or a talk regarding the use of various psychotherapies in palliative care?
Psychotherapy, there is no particular session for that, but in every session we used to incorporate that. Okay, anyway, in coming session, we will try to incorporate more on that. And psychotherapies, what we used to follow is we should get support from psychologists, if any. Another thing we used to do is we used to give time for the patient for opening up. Okay, that itself can cause make them get some relief. Okay, another thing is we should make use of psychologists, if any. If there is no psychologist, I know the limitations in every hospitals, we may not have any psychologist. I think you are asking about the same, isn't it, Dr. Priyanka? Am I answering it to your question?
Ma'am, yeah, actually, ma'am, I just wanted to ask because I personally feel sometimes that I should be able to somehow give some sort of psychological support to the patient in form of psychotherapies that we have studied, like maybe mindfulness or maybe some CBT, cognitive therapies, so that we can just contribute a bit, because every time it's not possible to refer the patients to psychologists or psychotherapists. So
Yes.
as it is a part of palliative care that we all are discussing, so I just wanted to request if it's possible, or if you can just guide, like there is going to be a session later, or there's some different sort of course or foundation course or something like that where we can learn that also.
Yes, I understood your concern, Dr. Priyanka. Anyway, we will mean it and we will discuss it with our team. Currently, we don't have any session on psychotherapy. We used to hire a psychologist. Why? Because while doing a palliative care in our setup, a psychologist, social worker is very most needed. Why? Because a doctor alone cannot deal all the aspects. So anyway, we will discuss it within our team and we will inform you on that. If possible, we will try to incorporate that session in this, but I'm not giving you a hope.
Just adding in,
Yes.
like we do have a basic session on psychosocial issues, which will be faced by the professionals during their practices. But then, yes, the session would basically be focused on how to identify the same and then refer it to a professional psychologist who will be able to handle the same with much expertise.
Yes.
So
And
that is what we do.
Yes, we used to do that. And another thing is, Madam has mentioned in her session about the use of meditation, uh, uh, the visualization technique and all. So I know in our clinical scenario, we do not come across such practices. So you may have such doubts. Anyway, we will take it up, Dr. Priyanka, and we will inform you. Okay.
Thank you so much, ma'am. Thank you.
Yes, if it is not dealt here, I think you can.
You're always free to
Yes.
write to us in the WhatsApp group or write to us at tipseco@palliamindia.org with your queries or requests. We will definitely.
Sure, ma'am.
Okay.
Thank you.
We have another thing. Manoj Shinde has already asked about the same CBT and relaxation techniques. Anyway, we have one session related to psychological aspects. So we will see to include these sessions also in that. We will try to include that. And with this, we are actually running short of time. And thank you all for attending this session. And thank you, ma'am. Thank you so much. Actually, it's always our privilege to have you as our faculty for taking these sessions. Thank you for your time and your patience for taking this session and for clearing all our doubts. I know you may have so many doubts as well. So as Priya has mentioned, you can ask us any doubts which is not cleared in any session. You can be open to us by asking through the WhatsApp group or any mail as well. Okay.
Thank you, Dr. Rajani. Of course, we missed seeing your vibrant face and your always sweet smile. We missed that. But then again, as usual, an outstanding session with a lot of information. I hope everyone would agree to that. Thank you for joining in. And we do hope to have more sessions with you in future as well. And thank you everyone for joining in. And with the promise that we will be meeting in the next session with another very relevant topic and an experienced faculty. This is Sri Priya, along with Dr. Rajani Surendar Bhat and Dr. Grishma Nair signing off from the Tips Eco Hub. See you in the next session. Till then, everyone, take care, be happy, stay safe. Bye-bye.